Hello, everyone, and welcome to today's webinar, Reducing Complexity and Increasing the Value of Molecular Viral Load, STI and Transplant Virus Testing with Middleware. I'm Susie Valdez of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Abbott Molecular. To learn more, visit them at www.abbott.com. So let's get started. Before we begin, I want to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have any trouble seeing or hearing this presentation, simply click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I now present today's speaker, Michael Sutch, the Senior Manager at Solutions Design Team for the Americas. For a complete biography on our speaker, please visit the Biography tab at the top of your screen. Michael, you may now begin your presentation. Welcome.
Great. Thank you, Susie. I really appreciate it. And thanks, everyone, for joining today. I'm very excited to be presenting this topic. I think it's very contemporary for what's going on in molecular. My hope today is that you walk away with a lot more information than you had before, that it spurs interest on your side, and that you spurs also some action on your side to really bring up molecular to the next level in its testing. The first slide I want to show you today is really one from the archives. I think everyone probably recognizes Juran. He was one of the giants of quality, and he'd written a number of studies, based upon inspector accuracy, meaning 100% inspection of whatever was taking place. And it began really following World War II. The downside of all this great work was that he discovered that that kind of inspection after things have completed, is really about 87% effective. And he gave this great formula to calculate the accuracy of an inspector. And I won't go into it, but it really brings us to the next question. What is effective inspection? From a pure probability standpoint, multiple inspections of data are indeed effective, right? We can determine, however, that 100% inspection is about 85% effective, and we can calculate the probability. So what I wanted to get to is we need to rationalize and move on in molecular that inspection really isn't the best way to ensure quality. And so that brings me to our next set of learning objectives. At the end of this presentation, it's my hope that you'll understand the role of middleware in the context of both lab information systems and the ever-evolving EHR, the data sharing and reporting process. It's also my objective that you're able to better compare and contrast between the functional benefits of adding middleware to a busy molecular lab. And last but not least, it's really about helping you identify and define a basic validation plan that satisfies your local requirements. And I'll talk a little bit about some CLSI guidance. It's my belief as a person operating in the molecular world that we need to elevate this inspection process beyond inspection and to make it much more of a data-driven, data-decided, auto-verified world. And I'll show you more about what that means. From a flow perspective today, I think it's important that we examine some of the history, because history tells us where we are and it gives us a good indication of where we need to go. I'm going to go over a fairly limited set of definitions. I wish we had a couple of hours instead of just an hour, but I'll give you a taste of some of the definitions of words you may not have heard of before. I also want to talk about the current status. I'm going to build on some practical examples. I'm going to also talk about a cost-benefit context. I'm going to get you to the point, hopefully, where you begin thinking about a needs assessment. And I also want to conclude with some references to some CLSI guidance that I think would be really important to people considering tripping that threshold and implementing middleware. And then I want to conclude us with a set of question and answers where hopefully I can shed some information about our experiences at Abbott Molecular. So one of the things I think is really fascinating, this is a graphic that was created, developed by the Joint Economic Committee. It was led by Senator Sam Brownback of Kansas and Republican Kevin Brady of Texas. They created this at the Congressional Joint Economic Committee back in 2010. And what this is a diagram of all the relationships that crisscross between hundreds of government offices, departments, and programs. And it's in a maze of boxes, circles, and triangles, and other assorted shapes. It's actually missing a lot of other parts and pieces. So imagine how complicated it makes it, right? This is specifically for Health and Human Services. Imagine how complicated it makes for the 900,000 U.S. physicians, laboratory, and other health professionals. This is just describing the interactions, right? This is kind of a typical government response. So the reason I highlight this is because we need to get to a simpler interface. We need to get to an approach where we're making data much more digestible for health professionals. Now, this next slide, if you've ever read this book, this report, it's really worth getting a hold of. It's a consensus report that was published by the NAM, the National Academy of Medicine, along with a number of sponsors from teaching institutions across the U.S. The author's key message is that it's important to take a systematic approach to address burnout that focuses on the structure, the organization, and generally the overall culture of healthcare. You could argue, why am I showing you a report about physicians? Well, I'd say that it affects all allied health professionals equally, including laboratorians, right? The overwhelming focus on the impact of increasing complexity and really the need to improve IT-related processes and how information is given to people. It's the backdrop of all this. So what is this pathway leading to molecular? I really got to give you some history and give some credibility here because I want you to see where we came from and where we are today. And this is my opinion, but it really began back in 1966, right, with the advent of a program called MUMPS, which stands for the Mass General Utility Multi-Programming System. It's a general purpose programming language that provides what they call atomic, consistent, isolated, and durable transaction processing. Now, MUMPS was developed by two people, Neil Pappalardo and Kurt Marble, in the late 1960s. And this hospital used it originally in the admission cycle and also for laboratory reporting. Eventually, now the usage of MUMPS spread throughout healthcare, and it's actually used as the programming language for most of the early EMRs, right? So it was pretty much adopted to the 70s, and in the early 80s, it spread from healthcare into financial, and ironically, it's continued to be used by some of the same clients today. It's used in electronic health record systems as well as multiple banking networks, online trading. So it's got the basics of what makes sense, and it's actually really good. In my opinion, the advent of MUMPS was really the sentinel event that got us where we are today with the use of logical programs in the hospital lab space. So, I'm still on the history part, right? So this path leading the middleware. I've got to give credence to Dr. Jack Ladenson, who ironically is still on staff at Washington University Med Center in St. Louis. He's a professor of pathology and immunology. He came up with the idea of one of the first ideas of applying logic, which was the delta check. This is in chemistry, right? And for those of you who don't recognize this term, it's a software logic check procedure that compares the current result to the previous result from the same individual using a specified cutoff value. Now, that specified cutoff value represents the maximum allowable change that is acceptable for whatever the laboratory procedure is. The cutoff value could be presented as an absolute change, a percent change, a rate of change, or a rate of percent change, depending on what analyte we're looking at. Amazingly forward thinking for back in 1975. So think now, a dozen or so later years comes on the scene Data Innovations. And you can read their full story. They came on the scene in 1989 with a focus on the laboratory versus the EMR. It's a great company that continues to evolve and improve connectivity and insights. But this is where it began, right, folks, back in the 70s and 80s. And they were the first true system to connect and really begin managing discrete instrument data from within the laboratory. I'm almost done with history, but bear with me a second. This is the actual excerpt from Dr. Jack Ladenson. I thought it was really timely. I wanted to show you that in 1975, someone was thinking about how they use technology and IT to actually catch errors in laboratory data. Amazingly forward-thinking. So a little bit more history, albeit it's my interpretation, right? It's a fairly recent event to have middleware in the traditional chemistry, immunochemistry, urinalysis, et cetera world. It's perhaps even more new to molecular. And I'm showing you in this picture what were three distinct yet isolated instrument tools used in the Clin labs in the 1970s. The SMAC, or the sequential multiple analyzer, that was used for high volume chemistries. The ACA, or the pouch chemistry from DuPont, that was used for discrete chemistries. And then a general use spectrophotometer from Milton Roy. Okay, so enough about history. My intention is that you start seeing more of the analogy between where chemistry was and is today and where molecular viral load, STI, and transplant is headed. So let's move on now to the future. So I think it's important to level set on some acronyms. The Hospital Information System, or HIS, is often the term used to describe all the elements of a patient record. The electronic health record of a patient is updated with all that testing information. So whereas the EHR is kind of a more real-time patient-centered documentation, it's really there to make sure that the health info is available instantly and it's really securely captured to authorize users whenever they need it. EHR systems are built to share data between healthcare providers, organizations, laboratories, specialized experts, imaging facilities, pharmacy schools, et cetera. You know, an average electronic healthcare record contains, and it continues to grow, demographics, history, statistics, treatment plans, allergies, immunization dates, radiology, vital signs, in addition to lab and administrative billing. So what has advanced at the hospital level is a proliferation of specialized systems to make sense of and categorize digital images and other discrete pieces of information that HIS can't sort out or isn't capable of rendering into useful information. Now, likewise, you have the LIS in the same situation, the lab information system. The LIS alone really isn't capable of many of the facets of information management, categorization, and reporting. So I may draw some criticism for that statement, but it's why middleware is popular and gaining popularity in the laboratory. So let's finally turn our attention away from all the history and anecdotes and talk specifically about middleware. So what is middleware? It's basically software that sits on a high-capacity PC, and that could be cloud-based as well, that has the physical and logical connection abilities to various lab instruments that are capable of communicating by one or more protocols, whether that's serial tunneling or whether that's using the more up-to-date standard HL7 protocols. It's middleware is helping to make sense of a whole lot of discrete information, and it does so by employing some set of rules or a rules engine that governs the disposition or the next steps or the transformation of that discrete testing information. Now, oftentimes it's modular, right? And that depends on the vendor, right? It could include things like sample tracking, extended quality control, charting, and providing access to review by other open data sources, and a whole lot more. This all depends on the vendor. But all these additional modules are all capable and resident in various systems out there commercially available. So I wanted to make sure that we kind of demystify that middleware is nothing more than another computer system with rules and modules that govern and give more granular control to lab information, right? This sort of summarizes it as well, right? The middleware is any number and type of extraction and amplification instruments, discrete, standalone, all working independently, but interfaced bidirectionally where possible. And what that's going to afford you as a user, and this isn't meant to be an exhaustive, it's really a proportional to your imagination, because the contemporary middleware systems out there are really capable of almost any kind of data merging and extraction, but it's really meant to provide a single point of management for results, both results that are discrete or panel results. It's meant to give you multiple instrument status in one single console. It's meant to give complete centralized maintenance records from all the instruments that might be interfaced. Its real strong ability is to create what I call composite results, and looking at data longitudinally over time and space to look at trends and things and be more prognostic. It also allows, obviously, rules development and enables auto verification, which we're going to spend a little bit of time on, and other quality checks. But it really is only limited by your imagination and programming expertise. It's nothing more than a way of managing discrete data and categorizing it in a way that makes sense for your laboratory. Now, what I want to focus on is some common rules, and the one that's probably most familiar to most people in the audience today is auto verification, AV or auto verification. Like I said, it's probably the most common rule in a rules engine. Applying auto verification rules can remove the need for what I consider to be rote human inspection of results. I'm not discrediting the results and inspection, but this advent of having people review or having two people review data is really not contemporary. For example, all negative serology results coming off an immunoassay analyzer, or all electrolytes that are in the normal range, those are typically automatically auto-verified in today's chemistry world because there are controls set in place, there are value checks set in place, whereas a human adds no extra additional value. Human inspection in the molecular laboratory, usually via paper printouts, has been the norm. But it's been automated via middleware rules that can automatically apply validation criteria, verification criteria, and render a judgment. Some folks in the audience are probably nodding their head, they're already doing this, but it's my understanding that the vast majority of people had not even begun to apply auto verification because they've never been exposed to it. We can learn a lot from the world of chemistry. So I want to turn your attention to some limited definitions that I've put on screen, and it's my understanding that my presentation, along with these definitions, will be available after for you to reference, so I won't read through them all, but here's some common definitions that may be somewhat foreign to some of you, but it really comes down to the idea of applying program logic, right? Auto verification, I'll read this rule, is a rules-based decision process using computer rules to verify the lab results. It's going to look at all the indicators as far as quality control to make sure the result is valid. Now, a lot of this is set up by the user in conjunction with help from one or more of the commercial vendors, but it's probably the most powerful tool you have to release results more early and to free up those resources that might otherwise be doing 100% inspection. The rest of the definitions are self-standing. I won't bother to read them, but I wanted to make sure that you had a limited set, at least to refer to as we go forward. I like to refer to all this as the iceberg of possibilities. We're so much accustomed to looking at test results, right? The iceberg represents the potential, and there's currently a number of things that are visible, like I show above the surface, right? But the future is relatively unlimited, but it's a progression, right? Especially for molecular labs where some needs are not fully understood or fully realized. There are a number of things middleware can accomplish. Commercial systems have those modules that I've described and add-ons to achieve a variety of endpoints that really are probably otherwise impossible to achieve, or really probably rely too much on people resources that frankly most of us labs don't have. So focusing on auto verification is probably the most easiest one to tackle, but there are lots of patterns that can be looked at. There are prognostic tools that can be applied to this. It's all really proportional to your imagination. So I wanted just to share with you a few potential rules to consider, right? And these are coming from my experience in traveling around the Americas. An excellent source of inspiration or unmet needs could really include the physician community that you service. Here's just a partial list of what I've come up with and some that I've seen implemented in various countries and jurisdictions and what they intend to accomplish in a molecular lab setting. For example, in the situation of where a viral load and a genotype are ordered at the same time, it's possible to automate the cancellation of the genotype if the viral load is undetectable. Sounds pretty pedestrian, right? But it's actually something that can be easily implemented, whereas otherwise it's probably relying on a human to remember to go cancel a genotype because it's no longer necessary for a viral load that's undetectable. Another example is if a dilution is required for a sample that's above the upper limit of detection, automatically hold that result, automate some suitable message to the LIS or clinician, and automatically order a retest. So that's a little bit more sophisticated, but it's the idea of combining what are normally steps that are followed by SOP by a person and having the system automate the transaction. Another one I think is powerful is that for a positive STI, automatically retrieve the past test results and combine it into a single report. This can all be done in middleware. If the previous result was completed in whatever day window where there might be actually picking up residual DNA. Again, these are all attempts at stewardship, at better management, and in my opinion, some of these are being done manually where they could be done automated by programming exercises into a rules engine in middleware. So this is all about supporting and improving the human element, looking for what I call defect salience, which is stuff that may be occurring that you don't see. It's about supporting combination reporting of taking two discrete pieces of information and joining them together for physician's benefit. It's about looking at trends in reporting in a different way by looking back at data and across your enterprise. And it's also supporting what I air quote as better interpretation. But I put the infinity symbol there because it really is only limited by what your thoughts are. Now, here's a few more to consider as well. Automatically ordering an HIV genotype if the viral load is ordered in positive. Capturing serology results to generate a composite result, right? Serology should kick off the process, but it's all about combining. And this is actually from a customer example I have where they called it test and treat. So they give results that otherwise may be relegated to the physician to go gather himself or herself, put it in a composite report. Another one is if high-grade viremia for BK virus is detected, auto-order a second urine sample within 2 weeks. And this is following a specific manufacturer's package insert. If the 2 consecutive urine samples show high-grade viral present, auto-order what is considered to be the next appropriate sample, which is a whole blood or plasma sample, not a urine. So automating those processes, again, that might otherwise be governed by ASCP can be driven by a rules-based kind of approach. Probably the most common one I see out there is the last one I show on the list around sample unit conversion or changing values automatically for different physicians who want to consume either log or other values differently. So those are just a few of the items I wanted to talk about. It really is limited. Talking to any one of your commercial vendors who have middleware solutions will give you many more ideas. The implementations really, when they're done correctly, should result in a dramatic reduction in paperwork and the review time that we all normally do. It should dramatically increase your turnaround time. By my estimates, on average, an average run of a viral load testing, let's say it's around 50 samples, probably has about 20 minutes of paperwork review. And I'm not saying it's discounted and not valuable, but there are ways to automate that to recover much of that time to remove the human element. You're also less dependent on staff and attentiveness and skill level. I've been at several institutions where if the primary operator is gone, someone else who's less skilled has to operate. And you in that situation, they probably experience a little bit of a lessening of the service level. Again, the whole idea isn't to replace people because we're the ones that drive the process, but let's automate things that are more rote and routine and let the skilled, experienced people focus in on more of the special cause issues and things that really require much more thought. It also, in my opinion, and we've yet to demonstrate that, but I'm working to demonstrate it, is it offers better adherence to SOP and process definitions. Automating things that are normally relegated to a human being who can forget, can get distracted by phone calls. That's what it's all about. At the end of the day, it's about more results released with a higher confidence of their validity. So I promised I'd talk a little bit about some of the CLSI guidelines. Don't fault me. The last time these were updated was about 15 years ago, but in reviewing them, they're still very, very much on point for setting the stage for not only managing the validation framework, but also giving you insights as a new user about which frameworks you consider in planning the testing process. So both Auto 80A and Auto TED-A, both are worth purchasing. They really go over, even though they're a little bit dated, they go over really all the test cases around stress and boundary that should be included as you verify and validate your middleware implementation. It's pretty straightforward. These are the backbone 2 documents that are out there that really govern and give an idea. And certainly the vendors of these systems are well aware and can help you with putting together a really good validation program. But these are 2 of the guidelines that I think are probably the most specific and offer the most specific guidance and use the nomenclature and verbiage and approach that any inspector would want to see. One of the things I wanted to bring to your attention, there's a growing and still expanding audience of organizations out there that are trying to evolve this whole process of communications and data analysis. The IVD Industry Consortium Connectivity, or ICCC, is a global, it's a nonprofit organization that's really dedicated to creating and encouraging all this unified connectivity standard, because not every system out there is functioning the same. It's all about reducing the cost and the variability of the data exchange between the IVD devices and healthcare informatics in the clin labs, because we're not there yet. The law, the laboratory analytical workflow profile, and all these are available, by the way, on the internet, really addresses that exchange of information related to patient and the QC test orders and the results between systems and health informatics, because it's evolving, folks. Obviously, I think we all know that it's not there yet. The purpose of the law profile really is to improve interoperability between IVD testing systems and those informatics systems. And most all of our contemporary vendors out there that are producing chemistry or molecular systems have adopted the law profile, but not fully, so you need to be aware of that. I just bring it up because I want you to understand there are groups and organizations. Both of these offer insights and opportunities for you to increase your knowledge, so I wanted to bring your attention to them. So in summary, you really can't automate confident release of a molecular viral load, STIs, and transplant testing. It doesn't need to be, it isn't 100% by applying 100% inspection. Even applying 2 or 3 people mathematically doesn't get you to 100%. I'm not saying we're releasing poor results. I'm saying that if you really want to achieve perfection, you've got to automate it with something that doesn't get fatigued. It's going to provide confident results faster. Now, you can trigger events, and you can be as conservative as you want for meeting some of this. It's really limitless. You can institute delta checks. You can approach this gradually, right? Middleware and an introduction into molecular is really a progression. It's not meant to replace everything and anything. But the advent of random access testing from vendors and quick result being generated and automated process control being much more evident on the instruments, to me speaks clearly to the need that we need to be able to release those results confidently as they're made available and not be stuck in our batch mentality. And there are multiple middleware vendors out there to compare and contrast. A lot of the LIS vendors are now getting in more into this space as well, and they're bringing their own solutions. You know, Data Innovations is one I've mentioned already. I'm sure a lot of us have familiarity with them. They were the pioneers. Other sources exist out there as well. I encourage you to talk to DI and others because there's lots of opportunity for different decisions to be made. So I want to end with a couple of comments too, right? The rule writing doesn't have to be complex. It can evolve over time. Some of the rules can be really sophisticated if you study what's done in hematology or urinalysis. Those are meant there to be learned from and perhaps extrapolated from, but you don't have to start off with every single thing being automated. Like I said, the sources for V&V support, both the dry test and the wet test that you'll need to conduct, are available from the CLSI. from vendor, and there's a host of other online resources out there. New directives for interoperability, getting us away from the old serial standards and getting us into HL7 are all available, and the advent of them is out there online. So hopefully today I left you with at least an understanding of where history has taken us, where the future can lie, and some glimpse into some of the resources that might take molecular to the next level when it comes to data management and writing reports and using rules engines. So Susie, I'll turn it back over to you.
Thank you so much, Michael, for that informative presentation. And we will now start the live Q&A portion of this webinar. If you have any questions you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many questions as we have time for. So let's get started and take a look at some of our questions coming in now. Michael, our first question from an audience member is, what are the vendor options that are available other than Data Innovations?
Oh, great question, Susie. I didn't want it to be a commercial because Abbott have a system as well. It's called NAHQ AMS, and it's a middleware version that's meant to operate agnostically across the spectrum, and it can work with molecular as well as chemistry, urinalysis, et cetera. So my own company has their own solution as well, but DI is one. There are other variations out there, like I said, available from Cerner, Sunquest, and Meditech. I don't have quick access to their names, but each one of those LIS players has middleware-like options that can be employed in the molecular space as well.
Thank you for that. And our next question is actually a two-part question. Michael, is it practical to just add middleware to molecular, or should I talk to the other lab departments about piggybacking onto their agreement with their current middleware vendor?
Wow, that's a good question. Yeah, I mean, there's no doubt that every contemporary clin lab out there that has a molecular lab as well is probably employing some version of middleware. So, my suggestion is that don't reinvent the wheel. Talk to your clin lab counterparts. Figure out what they've been doing, how they've automated, because it could save you money and time on licensing. It could also save you some resources as far as the validation approach, because realistically, molecular testing, although complex, is not necessarily any more complex in its review than a lot of sophisticated chemistry, immunochemistry tests as well. So, if you can piggyback onto a Data Innovations already existing install, that's the better way to do it. It might save you hardware and software and garner more support. So, yeah, definitely talk to your clin lab counterparts. I found that oftentimes molecular labs are physically and logically isolated, but I don't know why that is. I just think there's opportunity to encourage people to talk to their clin lab counterparts and say, hey, what are you guys doing with advancing your control and management of data? How can I be a part of that?
Thank you, Michael. And these are great questions coming in. Our next audience member wants to know, what is the approximate cost, and are there reoccurring fees?
It depends. Yeah, no, it's all about what you want to do, right? So as I mentioned in the presentation, vendors have different levels of access and support. They have different modules. They've made it modular for a reason, because they want people to pick a la carte what they need. I would say the approximate cost to get started with a basic installation is probably, including hardware, is probably in the $20,000 to $25,000 range. Now, that doesn't include some of the consulting time you might need and what they call thin client connections and a host of other things that, the vendors are much more able to explain to you. That's about the threshold to start doing it. And I know they also have cost models to demonstrate, where you're going to get recovery. So I'd encourage people to look at that. Like anything, there's a lot of recurring, not a lot, there is recurring fees for support, for telephone support. And as you advance your skill set and knowledge and you program more rules, there's recurring fees that are associated with that as well to consult with the vendor. They're pretty nominal, but it's something you should account for.
Thank you. And we have time for a couple more questions. Here's a great question.
Great.
Who writes the rules you spoke about, and does it require a degree in computer science?
So the rules are generally constructed as a joint project between the vendor of the system and someone who's identified in the laboratory who really understands the process. It doesn't really require a computer science degree. Some of them do have what I call scripting language, which you need to get a little bit familiar with, but it's, in my opinion, it's not any more sophisticated than programming a formula in Excel. So you don't have to have a degree in computer science. Maybe you did back in the 80s, but fast forward to 2020, it's not required.
Great, thank you. We have time for one more question, and this audience member asks, your example rules are interesting. Who creates the rules, and what is the typical governance process for maintaining, editing, and creating new or revised rules?
Wow, these are great questions. So the rules are generally as a result of an unmet need or an aspirational need within the laboratory. A good way to start is looking at who is actually looking at data today, and what are they doing with it? In my experience, some institutions are looking to actually plot demographics and understanding where there's incidence changes or prevalence changes, especially around sexually transmitted disease. So starting there will help give an idea of what can be kind of automated and pulled into a report that doesn't require a human. The governance process is typically multifold. It's usually someone in the core laboratory, but also someone who represents the quality function, and someone who typically, in the case of STIs, is generally someone who is tracking epidemiology or other areas. Typically what happens is there's a meeting that gets convened on a quarterly basis when there's new rules promulgated or promoted for review by pathology and the people that I just mentioned. And then the process goes that there's a dry test portion, usually in an off environment, and then there's a wet test portion where they actually run samples as part of the validation. And then once that activity is completed, the rules are in place and staff is updated, and you run and roll.
Thank you so much, Michael. And do you have any final comments for our audience members?
My only comment is to think about your process holistically. I know a lot of laboratories around the Americas, at least, have multiple discrete systems, and you've got multiple operators doing individual things. Just think about the power of being able to combine that, especially in the advent of today's more contemporary systems that do all this testing that release results every hour or every frequency. Get out of the batch mode mentality. You don't need to be there. Think about the implications and the value to the patient and the provider if you're able to release results a heck of a lot earlier. What interventions or what data or what decisions can be made, even if it's a couple of hours, that might benefit the patient. So don't be afraid is my thing. Challenge the vendors, encourage them to get involved with your solution set, and get as much information as you can to make a good decision. I think the time is now to consider and do this.
Michael, thank you again for your time today and for your important research. I'd also like to thank LabRoots and our sponsor, Abbott Molecular, for underwriting today's educational webcast. And before we go, I'd like to thank the audience members for joining us today and for their interesting questions. Questions we didn't have time for today, and those submitted during the on-demand period will be addressed by the speaker via contact information you provided at the time of registration. The webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share this email with your colleagues who may have missed today's live event. Until next time, bye-bye.